So welcome everybody to our new and improved grand rounds, the last one of the year. I would like to start with a minute of silence commemorating the end of slavery. Thank you. Without further ado, I'm going to pass it on to Dr. Leedy.
All right, thank you, Dr. Young. And hello and welcome everyone to the Department of Medicine Grand Rounds. I'm Doug Leedy, one of the chief residents here at UWMC. And along with me today is Dr. Brad Annewalt, Chief of Medicine. And together we'll be your moderators for Grand Rounds. And before we go and introduce our speaker, Brad and I will be introducing some of the annual awards that are typically presented over a series of grand rounds in the spring. Now, the novelty of walking up and receiving an award in front of a crowd can't be replicated over Zoom, but leave no doubt that today's awardees have earned our respect and admiration for their dedication to our patients, the University of Washington, and the surrounding community. And with that said, Brad, do you mind opening up with the first awardees?
So we have the Outstanding Medical Student Award for 2020. The Outstanding Medical Student Award is given annually to the medical students entering internal medicine as a career. These awardees exemplify the Department of Medicine values of providing outstanding patient care, modeling compassion to patients, family, and friends, and demonstrating high professional interactions with attendings, residents, fellows, hospital staff, and fellow students. This year's Outstanding Medical Student Award recipients are Melit Asifa, Alexander Hoffman, Natasha Steele.
All right, congrats everyone. And for the Robert S. Evans Award, this award is presented every year to one graduating medical student and one second-year internal medicine resident. And it recognizes the special qualities of warmth, understanding, and compassion and concern of the needs of others as exemplified by and expressed throughout the life of Dr. Robert S. Evans, who served here as the Chief of Medicine for many years at the Seattle VA. The 2020 Robert S. Evans Award recipients are James C., Internal Medicine R2, and Shiv Bandari, fourth year medical student here at UW. Congratulations to you both.
The next award is in recognition of Dr. Paul Beeson. Dr. Beeson was the editor of the major textbook that we used in internal medicine in the last millennium, back in the days when we read books. It would be the equivalent of being the editor-in-chief of Up to Date. He was a gentleman, a fine scholar, and a wonderful teacher. He was a distinguished physician at the Seattle VA Medical Center from 1974 to 1979. The Beeson Award is presented annually by the internal medicine residents to recognize outstanding clinical teaching by a faculty member who exemplifies scholarliness, humility, compassion, and integrity. For the 2020 Paul Beeson Award, the residents have recognized Dr. Tyler Albert at the VA. I can think of no finer person for the residents to select this year. He's a wonderful teacher and he loves the physical exam, which Dr. Beeson venerated. Congratulations, Tyler.
Yes, and congratulations to everyone. And Brad, before I introduce our speaker, Dr. Laura Evans, do you mind giving the crowd and the audience kind of an overview of what to expect with this new Zoom-only format for Grand Rounds?
Thanks, Doug. So just a reminder that we're making Grand Rounds a bit more interactive. We're taking advantage of Zoom. So at any point in time, you're welcome to send comments or questions through the chat mechanism. For those of you who have not spent days on end on Zoom, that's the little icon at the bottom of your Zoom screen, and you can click on that and type in a question. You can type into everybody, or you can type into Dr. Leedy or to me. We have advised Dr. Evans in advance that she may get a question or two scattered throughout her talk. I can think of really, truly no better person to give this Grand Rounds and participate in this novel style. I just got to know her during the COVID pandemic. She is the epitome of calm and cool in a crisis, as well as having wonderful energy and enthusiasm. So that's the backdrop here. We will also curate the questions and ask questions at the very end for Dr. Evans. If there are questions that can't be answered because of time constraints, we'll propose that Dr. Evans review them and potentially follow up by email if that's possible.
Great, thanks, Brad. So it's my pleasure today to introduce our speaker, Dr. Laura Evans. She's an associate professor of medicine and the medical director of critical care here at UW Medical Center. And she earned her medical degree at University of Michigan and then did her residency in internal medicine at Columbia University. She completed her fellowship in pulmonary and critical care and earned a master's of science in epidemiology at the University of Washington. She then joined the faculty of NYU and Bellevue Hospital in 2006. In her role there, she led the evacuation of Bellevue Hospital's ICU in the aftermath of Hurricane Sandy and was also the clinical lead for New York City's only patient with Ebola. After 14 years in New York City, she returned to Seattle this last fall. And during the COVID-19 surge in New York, she went back to Bellevue Hospital in April as a volunteer. So today she'll be sharing some of those experiences with us. So please join me in welcoming Dr. Evans as she presents the COVID-19 pandemic in Seattle and New York City, the similarities and differences. Dr. Evans.
Thanks so much, Doug, and thanks, Brad, and thanks, Barbara, for the opportunity to be this. It's a real honor, particularly, and I especially want to congratulate all of the awardees and also all of the residents at the conclusion of what has certainly been a most unusual academic year. And so I think everybody deserves lots and lots of kudos and credit for all that they've done. So I'm going to make an attempt here at sharing my screen, and hopefully it will work. And maybe Brad or Doug, if you guys can give me like your visual, you went away visibly, so maybe you can give me a thumbs up visually if it's okay. Excellent. So I don't have any financial disclosures here to speak of from that. I do want to just give a little bit of overview about the context of this. Is not going to be a highly scientific presentation full of randomized controlled trials data, both because there isn't a lot in COVID, and that's also let me see if I can get this to, sorry, thank you for the chat, Paul. I'm going to try and change the view so it gives you the real view rather than the presenter view. Apologies for the difficulties here. Let's see. And we might have to muddle through with looking at the presenter view, otherwise I'll just make it bigger.
Dr. Evans, if you go to the bottom right, right there, does that work for you?
It shows on my other screen is the problem. So let me stop sharing for a second and go again. Hold on, new share. And let me try that again. It is doing the presenter view on one of the computer screens and not the other. So let's see. Otherwise, we'll end up with just sort of a weird view, and you'll get sneak previews of everything I'm about to say. It'll be super exciting. Okay, are you seeing just the presenter, just the screen view now?
Looks perfect.
Okay, so let me back up then. Apologies. So in terms of context, we're going to talk a little bit about starting at sort of the regional view and then going towards more of a city view and then a hospital view from that, and talk a little bit about some of the similarities and differences from that. This will probably look familiar to many people because I think everybody's been sort of following epi curves and case counts pretty vigorously from that. I'm a personal fan of the New York Times website because you can kind of plug in lots of different geographic regions, and I like the visual display from it, but there's obviously tons of good resources out there to look at this. So this is the Washington State epi curve. And I just want to call your attention to a couple elements of it. One is that it starts very early in March, which I think we all know that we were on the leading edge, for good or for bad, of the COVID-19 pandemic in the United States. Then we saw a peak in early April, and then a rapid decline, and then this very long plateau, which we're still hovering around at. And as of a couple days ago, our daily case count in Washington State was 372 cases a day. I want to compare and contrast that with the epi curve at the state level from New York State, which you can see started later on. So it really didn't start until the middle of March, and then climbed extremely quickly to a very high peak. And the peak case count in New York, in the middle of April, was 10,000 cases a day. So it's very significantly more than Washington State, and then fell relatively quickly and has continued to fall. And so whether New York will end up in this sort of long plateau where Washington State is, I think we don't know yet. They certainly still have more cases on a daily basis than Washington State does, but the curve still seems to be on the decline in New York State, whereas in Washington State, we're at more of a plateau right now. I think there were a lot of similarities in what each region was experiencing around April. And these are two pictures that I took related to my travel back to New York. And on the left, we have the arrival zone at SeaTac, which was, as you can see, pretty empty. And on the right, you have the arrival zone at JFK, which is, as you can see, pretty empty. Certainly was very shocking to me as somebody who travels a fair amount to see airports that looked like this. It was something I never would have imagined seeing. And similarly, when you get to the city level, I think the visual of the city was very similar. So you have downtown Seattle on the left in the midst of the highest level shutdown. And then on the right hand, you have a picture looking up Lexington Avenue towards the Chrysler Building in the distance. Now, this also happened to be about 6:30 in the morning, but you'll never see Manhattan anywhere close to this empty. When you get down closer to the city level, again, these epi curves look somewhat similar, but I think have some other differences in it that are sort of worth calling out from that. So on the left-hand side, we have the New York City epi curve, which again didn't start until the middle of March, has a very rapid peak, and then a fairly steep but long decline to where they are now. I think the scale of these graphs is worth remarking on, and that the scale in the New York City area, cases per day, was 15,000 cases at the upper margin here of this graph. And in the Seattle area, again, we had a relatively rapid rise from early March, a little bit longer and slower decline, but the peak daily caseload in Seattle was much, much, much lower, even on a per capita basis, but on this scale is 400 cases per day at the upper limit of the scale. As you would expect, the death curves are also very, very different in terms of magnitude. These are absolute curves, but when you look at it on a per capita basis, they're also similar. So New York City here peaked up above 1,500 cases of 1,500 deaths in a single day. That's that lone spike here, but had a period of time in mid-April where there were 1,100 to 1,200 deaths per day in New York City attributable to COVID. And then Seattle, we peaked probably just in the high teens, occasionally above 20 deaths per day. We're going to talk mostly about New York City and Seattle here, but I did also want to comment that we're going to talk, as we get sort of more and more granular in terms of the level that we're talking about, I think it's worth looking at the epi curve for Washington and the epi curve for Seattle simultaneously, because I think it reflects the experience that we're going to see is that this is not a homogeneous experience, even when you get to the city level, that there are real differences in the local experience to this. And so up here you have we already saw this graph. This is the epi curve for the state of Washington with this peak that was probably, as you can see looking at the curve below it from Seattle, probably driven by King County and Seattle. And then this very long plateau where we are now at the state level, whereas Seattle has continued to fall, albeit slowly, but has continued to fall. And this reflects, I think, what we're seeing now with the experience where there are hotspots in Washington state, predominantly in Eastern Washington, and most significantly right now in Yakima. And when we get really, really down to the granular level, we're hearing a lot about this, is that these epidemics, this pandemic, is not experienced universally and is not experienced uniformly. The effects of it are very unequal. And so this is zip code level data from King County Public Health's website and the New York City Department of Health and Mental Hygiene's website. And you can see that these zip code based maps are really spotty, where some zip codes are much more heavily affected in terms of case volume than other zip codes are on a population normalized basis. And in Seattle, in King County, you can see this is predominantly the areas most heavily affected are in the center and south of the city, a little bit to the north, a little bit just east of Lake Washington there. And also, I would also call your attention to the scale here, where the dark shaded zip codes here are at a rate of greater than 500 cases per 100,000 residents. If you look over at the right-hand panel of the screen, this is New York City. So Manhattan here in the middle is relatively spared compared to the areas of the city that were most heavily affected, which were parts of the Brooklyn, particularly central Brooklyn down here, Queens, certain areas of Queens. This is Elmhurst, Queens, and up by LaGuardia Airport, and a lot of the Bronx. So you can see that this is, again, a very heterogeneous effect of it. I would also remark that here, the case rate per 100,000, the light bars of the less severely affected neighborhoods here is 500, roughly about 500 cases per 100,000 residents, which would be the equivalent to the dark shaded areas on the King County map. We've all been hearing a lot, which I think is really worth reflecting on, is again about the inequities that are unmasked by this type of pandemic, where the effects on populations are unequal. And what we see is that age-adjusted rate, this is King County data, age-adjusted rates per 100,000 residents are very much different by your racial or ethnic group. So with Black residents of King County having a rate that's approximately 2.5 to 3-fold higher than white King County residents, Hispanic or Latinx residents, again, almost 1.5 times as high as Black King County residents. Asian heritage is approximately the same as the Caucasian group, and Native Hawaiian and Pacific Islanders, again, very big confidence bars here, but very, very high rates. And Aleutian Islanders or Alaska Natives, again, higher than the white ethnic group. The same effect, with not as many subgroups defined, not as many groups defined, is observed in New York City, with rates being much higher in Hispanic or Latino or Latinx residents of New York City, and much higher in Black or African American residents of New York City. Similarly, when you break this down by New York City reports this by percentage of the zip code level living at or below federal poverty level, and you can see there's a very strong dose response relationship between case volume rates per 100,000 population and the proportion of the population of that zip code that lives below the federal poverty level. So with lowest poverty levels of less than 10% of that zip code living below federal poverty level having the lowest cases, compared to obviously those with higher caseload in areas with greater than 30% of the population living below the federal poverty level. So I think this begs a lot of questions about why is this so much worse in New York City, or why is there so much more COVID in New York City as opposed to in King County and Washington? And I think there's a lot of theory out there. I don't know the answer to it. I'm not sure that anybody knows the answer to it. There's certainly a lot of discussion about it. Testing may be a key element to that. In Washington State, and particularly at the University of Washington, we were extremely fortunate. The virology lab here did an amazing job in setting up testing and rapidly distributing it and disseminating it. So the ability to test here was clearly much better than the ability to test on the ground was in New York City. There was also some discussion about the timing of non-pharmaceutical interventions. So did Seattle, quote unquote, shut things down earlier than New York City did? When did schools close relative to population-based or community levels of transmission? When did public transportation change the way that people got to work? Population density has been evoked a lot, but I think it's really interesting if you can remember going back to that zip code map of New York City and the relative distribution of cases. The highest cases distributions in New York City were not in the most densely populated areas of New York City. And with Manhattan actually has the highest population density of New York City, but had the least number of cases by population. And so there's a lot of theory that this is probably not, it's not merely related to population density just as a simple variable, but rather is more complex and probably more related to housing overcrowding and the population, that the proportion of the population that lives in overcrowded housing, which can be typically defined by greater than one person living per room in a housing unit. Certainly the use of mass transit can get a vote for that, and what proportion of the population may or may not have access to the ability to work remotely. And I think there's some interesting things that you can drill down that, if you go on the New York City Department of Health website, they actually break it down as well as into like case volume by percentage of the population that lacks internet access. And these are all, not surprisingly, I suspect to anybody in the audience, related to, associated with higher case volume. So let's move now into a little bit more of the health system experience. And I think there were some real similarities here in how the health systems experienced this. Both health systems, University of Washington, and I'll speak mostly about the New York City Health and Hospitals experience, which is the system that Bellevue is a part of, in addition to being an affiliate of New York University. They both took a real system-wide approach to this that focused very heavily on communication. And I think the UW Incident Command and Trish Critic and others and deserve a lot of credit for really focusing on communication and getting the word out. They focused a lot on the situational awareness. So what do we have in terms of information dashboards that help us manage our response? And I think both, though, also experienced the reality of having a lack of real-time detailed regional visibility about what exactly is going on, not just within your local hospital or local healthcare system, but in the systems that are related to it or the systems that are nearby. And those, I think, is something that we'll come back to that probably will be pertinent to future response. The main difference I would advocate is just in the magnitude of the event, whether it was a littler wave or a bigger wave. This may look familiar to some. This is from the daily UW Medicine report in terms of case loads across UW Medicine. This notably does not include the VA. This includes Harborview, Montlake, Northwest, and Valley Medical Centers. And you can see in early April, this corresponds to our peak. We had about 120 or so, give or take a few, 120 COVID patients across these 4 hospitals. In the early part of April. Those were broken down, and the ICU volume at that time peaked around in the sort of the low 40 number of ICU patients with COVID during that time period. I'm going to contrast that with the New York City Health and Hospitals experience, which is a bigger healthcare system. It's an 11 hospital system. It comprises the 11 public hospitals of New York City. From that, and you can see this, the graph is certainly represented differently as well. The blue bars here are patients with COVID, and the green bars here are patients without COVID. And this is over a longer period of time. So this is from the end of February till early June here. And this is across the entire system. So you can see on average, prior to the pandemic, the average inpatient census across the 11 hospital system was just over 3,000 patients. From that, you can see the green bars fell rapidly. So as COVID takes a hold, the non-COVID inpatient census drops dramatically to about less than half of its previous level, and the COVID census climbs very dramatically. So at some point in time in the sort of early to mid-April here, which corresponds to the peak inpatient census in New York City, about 2/3 of the inpatients were COVID patients, and about 1/3 of the patients were non-COVID patients, and they experienced about a 1/3 increase in their total capacity or total patient load over their baseline sort of levels. when you break it down to just Bellevue, so Bellevue being, again, one of the 11 public hospitals in New York City, Bellevue runs a census of about 600 or so patients on any given day. And you can see a similar pattern where the non-COVID patients drop pretty precipitously and the COVID census rises very dramatically. I think one thing that's worth noting is that the overall census didn't really climb that much. So if you look at the pre-COVID census here is sort of just on the high 500s, just around 600. In the peak of the experience at Bellevue, they're still having a census right around 600. So there was probably a little bit of a total surge in terms of patient number, but not a dramatic total increase in number of patients. But that certainly isn't what it felt like on the ground. On the ground, it felt like a big surge. And I think that's a reflection of the acuity of the patients, and there's so many very, 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 very sick patients. So the average acuity level in the hospital went way up, and it felt like an entire hospital full of some of the sickest patients that are, so you only have a few of on any given day. So it really felt very different, even though in terms of the overall absolute increase in number of patients, it wasn't really there, at least at Bellevue. Coming back to this concept, let me pause there. I see Brad.
Oh, well, Dr. Evans, you nicely went over some of the commonalities in communication at the two sites. We had a lot of questions and discussion about communication here at UW Medicine. And I'm wondering, what were some of the strengths that you saw that, for instance, we could have emulated or taken from your New York City experience or vice versa? Were there some themes that emerged about communicating the daily tracking of COVID admissions and the workload and really everything related to communication that might have differed from the two sites and you thought was stronger at one site than the other?
I think that's an interesting question. It's a tough one because I wasn't, my experience reflects a brief period of time there, not the sum total of the event there. And I think the key was frequent communication and ready accessibility of leadership at both sites. And so the ability to access leaders who knew the answers to your questions or could help find out the answers to your questions was probably more key than formal structured communication. So the ability to get individual questions answered, I think, was a key. And I think that happened in both locations, to be honest. It happened in different formats. Here, I think we used a lot of the town hall type of format. There, because of the pace and acuity, it was honestly just, I think, a lot of on the ground time on the clinical units answering questions. And I think we did a lot of that here as well, but they did less in terms of fully I don't know, scripted is the wrong word, but in terms of structured events like town halls, because I think there was just so much demand and volume that there wasn't the capacity to do that. I suspect they would have really liked to have been able to do that in order to get communication out more uniformly and to larger populations of staff. I'm going to go back to this slide now, and I know it's a little bit blurry because it's a screen cap, and but this is what they did across this 11 hospital system was this introduction of the concept of load leveling, which I think we hear about in other ways, but we didn't need to fully implement because we didn't have the same case volume that they did. And so if you look at the left-hand panel here, this is in the end of March, and you can see that these hospitals are sort of very differently affected by the number of COVID patients within this each hospital. And this volume or census did not correlate to overall hospital size or capacity. And then a very orchestrated effort was made to do a lot more load leveling across the system and distribute patients to hospitals by size and capacity. And so now you can see by the end of April or by the mid to April, the distribution of patients across the 11 hospital system looks very different. This is something that I think we'll need to come back to, and it's something that we need in terms of future directions, both New York City and the Western Washington region or the state of Washington, I think need to think about how systems like this can be implemented, not just within a healthcare system, but within a region, so between systems as well. tracking the surge, I think, was really hard because it was hard to categorize ICU patients because we're using ICU spaces that aren't typically used as ICU spaces. And so knowing who's quote unquote ICU status is not determined by location in this type of event. So a tracking system was pretty rapidly developed, and we sort of had a correlate to this here in terms of what level of surge we were in. But this was their ICU tracking system for level of surge. And so level 1 was essentially staying in conventional ICU space, but utilizing other ICUs for COVID care than you would typically use. So this, for example, would be going beyond the physical space of the medical ICU and using the neurosurgical ICU for COVID ICU. A level 2 surge was they defined as using other expansion ICU spaces, so using spaces like the PACU or the pediatric ICU, or anticipating potential ventilator shortage. Level 3 surge was utilizing what they called extraordinary spaces, which were categorized as operating rooms, general wards, parking lots, or expecting an imminent ventilator shortage. Level 4 surge was using all extraordinary space to maximum capacity, such as using single rooms as double occupancy, using ambulatory spaces. And a level 5 surge was absolutely no space and or no ventilators available anywhere. And this I know is blurry as well, but I thought it was an important visual to be able to portray about what this looked like across a hospital system and the pace and the sustained nature of the type of surge. So the hospitals here are de-identified. Again, this is the 11 hospital system here. And so it starts sort of towards the end of March. Most are in level 1 to level 2 surge. And then by the first week in April, you can see almost every hospital within the system is in either level 3 or level 4 surge. And if you go towards the end of the graph, which I didn't show, towards the end of April, mid to end of April, about 2/3 of the hospitals were experiencing a level 4 surge, and the other third were in a level 3 surge. Nobody did get to a level 5 surge. And I'll just remind you that level 3 was using extraordinary spaces, ORs, general wards, parking lots, or having an imminent ventilator shortage, and a level 4 surge was using all of this extraordinary space to its maximum capacity. So that's a lot of numbers and a lot of data about cases and admissions and surge levels, and it's abstract. And I kind of knew this going into New York, that what I understood the abstract sort of succession of how things were going, but it didn't really prepare me for exactly what that looks like on the ground. So let's talk a little bit about that. What does that actually look like? And so this is a photo on the left of the ICU at Bellevue. This is the medical ICU space, which would typically be that. All of the ICU space at Bellevue became COVID ICU space functionally. The only non-COVID ICU space was the PACU. Everything else that was typical ICU space became fully COVID ICU space from that. And it doesn't look so bad from the hallway, but you can see several things that look pretty abnormal. There are a lot of IV pumps outside the rooms, and we'll come back to that. And then this is actually, I should give credit to Vish for letting me share this slide, Vish Nair, who volunteered at NYU Hospital. So this is actually from NYU, but we had there was a similar setup at Bellevue. So this is the sliding glass door to an ICU room. And because of the volume of patients and the volume of information, people sought novel ways to communicate with one another. Going back, I think, Brad, to your question from earlier. How do you convey complicated information in an emergency setting where everybody may not have the time to kind of sit and parse through notes? And so the glass doors to all the ICU rooms became essentially communication tools, where you can see lots of lab data, plan for the day, by systems with that. And so this was, I think, a common and creative response to that. Again, a level 4 surge, that's a sort of an abstract term, but what does that look like? So this is a single ICU room, but there's obviously 2 patients within it. You can see the space is very crowded. There's not a lot of room between those beds. There's probably about 4 feet between those 2 beds. There's tons of equipment everywhere. There's tons of wires everywhere. This room is obviously set up to take care of a single patient. So there's an added monitor in the room. There's an added ventilator in the room. There's lots and lots of IV pumps everywhere in this room. And you can see that there's labeling done, because when you're looking at this from the doorway or trying to go to the room, which monitor belongs to which patient. So you can see this patient is this bed is now labeled bed Z within a room that's typically was one bed, one room, one bed within the electronic health record. And this one is labeled A. So this monitor goes to this patient, this monitor goes to the left-hand patient there. They did build in additional, so within the electronic health record, there was rapid builds so that all this information was captured in the electronic health record, but you couldn't build in the equipment into the central monitoring stations with that. So similarly, there were other pop-up ICU spaces that were designed here. This was a new, quote unquote, new 12-bed ICU space in the endoscopy recovery area. And this had a very different workflow than the traditional ICU space that was now being used to, supranormal capacity. So this became a kind of a hot zone ICU, right? Because there's no dividers between these rooms. And so people would don PPE, stay in this work environment for a few or up to several hours and care for multiple patients, doing hand hygiene and changing gloves in between patient care, but would stay donned in PPE otherwise. There were a sum total at the peak of 9 additional ICU teams needed to manage the surge capacity over normal operations at Bellevue. And the staffing of those teams were extremely creative. You can see they got so creative that they took 3 people from Seattle there. And so that in the photo there is me on the right, Vikram Padmanabhan in the middle from UWMC Northwest, and Neha Sathi, who's one of the Pulmonary Critical Care Fellows here at UW. So surge teams, there were lots of surge teams. They consisted of generally at least 1 critical care trained physician and a lot of redeployed staff from redeployed residents, redeployed faculty from other departments. I think here our plan had been to call them res attendings. There we called them super interns, no offense to faculty from other departments. But people were volunteered to fulfill those roles. Some of it was voluntary and some of it was a redeployment expectation. So for example, on the couple weekends that I was there, one of the quote unquote super interns on my ICU service was a neurosurgical attending that I had known from previous. And so he was doing neurosurgery during the week and volunteered to work every weekend as a super intern in one of the COVID ICUs. There were a lot of volunteer staff who came and I think most of the volunteers started arriving probably in sort of mid-April, right around the time that the 3 of us were there. And I think the biggest shortage, however, in terms of staff was not in physician or provider staffing. It was rather in nursing and particularly respiratory therapy staffing. And so the system went to a lot of agency and traveler staff in addition to volunteers to ensure that. So we had very interesting constructed teams. In order to maintain efficiency and situational awareness, there were procedure teams that were developed. And so teams of anesthesiologists mostly would be function as both airway management teams, central line teams, arterial line placement teams. Proning team existed, so they would go around and in the afternoon to prone anybody that needed prone ventilation. The team was comprised typically of an anesthesiologist and several orthopedic surgeons because they prone patients in the OR, so have experience doing that. And so they would go around about 2 o'clock in the afternoon and prone any patients that needed to be prone and go back around about 10 o'clock in the morning the next morning to resupine the patients. The trauma and acute care surgeons functioned both, some doing critical care and some being a kind of moving tracheostomy and peritoneal dialysis team. So there was a lot of peritoneal dialysis done on an emergency basis due to resource constraints around availability of hemodialysis. Unrelated to surge team staffing, I do want to make one note of this picture because there's something about this that should look really interesting to you. And this is the latest in face shield PPE fashion here. So as a means of keeping your PPE safe and clean and you knew where it was, as many people would wear a face shield, come out of a patient room, clean it, allow it to dry, and then wear it as a now novel type of crown. So you could see a lot of people walking around with the latest in PPE fashion. Similarly to surge teams, there was lots of surge equipment being used. You can see that we're here in this room, this again, double occupancy room. People are using a ventilator from the Strategic National Stockpile on bed A, and using what would typically be a non-invasive ventilator here used for invasive mechanical ventilation. Here, again, the pumps are outside the room as a means of trying to minimize both PPE use and trying to sort of conserve resources in that respect. And it became a really interesting and very difficult balance to try to strike between what resources are you trying to conserve, because you had to make very difficult decisions about, do I keep the pumps outside the room and you try to preferentially use medications done by continuous infusion, i.e. a drip, in order to minimize the number of times that somebody has to go into the room to conserve PPE. However, that uses a lot of IV pumps. And if you're short on IV pumps, obviously the trade-off you might make would be to go to intermittent dosing, so you wouldn't need to run things on an IV pump. So there was a lot of need for continuous reevaluation of where the most sort of pressing resource constraints were and how to best manage those. Okay, I see people.
Whoa.
Go ahead, Dr. Lee.
Yeah, Dr. Evans, your prior slide where you showed yourself, you know, obviously that's a very extreme and distressing environment and to walk into. You know, what was the institutional support given for, you know, staff, grieving staff, and then staff who were coming in like yourself? What'd that look like?
I think it was more informal than formal. You know, I can speak obviously best to my own personal experience, which is certainly not generalizable, because this is an institution. Remember, I had just left 6 months before. So I knew this hospital well. I knew many of the staff, obviously not the volunteers and not the agency and travelers, but I knew many of the people extremely well. I had worked there for 13 years and had been the director of critical care in this hospital. And so I think my experience is very hard to generalize from that. I think most of the support was predominantly informal, but it was really challenging for people. No surprise there. I think what is incredibly notable though is the sort of esprit de corps amongst these ad hoc teams. We think of ICU as a team sport, and that the team, and we kind of go the team. And these teams came together very quickly and had a really profound sense of camaraderie and a really profound sort of sense of response and duty and obligation. And so I think there was a lot of informal support that I felt it very strongly, but I think in terms of formal support, there was not a lot at that time. And I think that's something that may have long-term consequences.
Dr. Evans, I have an additional question, and a question that I'd like you to think about answering at the very end, not answering right now. Here, Dr. Leedy pointed out that you're in this very fear-provoking scenario where PPE is maybe in shortage, and you're worried about getting infections, and people are concerned. And at the same time, you're working in 2 academic centers with lots of smart people, and they're asking lots of questions about the pathogenesis and the infection rate and so forth. And you were a leader here. How do you manage those 2 very difficult streams of questions at the same time? The questions about shortages of PPE, very practical questions, and then people asking questions. I'm about to ask you the question that you may punt on for right now, but you had these sorts of questions. The question was, are we any closer to understanding the burden of asymptomatic or minimally symptomatic undiagnosed cases on the curve of the incidence of the disease? So those questions were being peppered at you at the same time you were dealing with PPE. So maybe you could answer that second question later if time allows, but how did you manage that information onslaught of questions?
I think I think you just do the best you can, right? And I think one element that's incredibly important is, as you already articulated, people are extremely intelligent. People get it. And so I think, to me, one of the central points is not representing certainty when there is uncertainty. I think it's much better to be upfront and about the level of uncertainty and trying to, approach this from we're just doing our best to mitigate potential risks rather than presenting certainty when we may not know precisely. And basically, expressing that commitment to continue to learn and adapt and change as we need to be as safe as we possibly can. And I think people, my experience is I think people respond better to that than sort of professing certainty when we don't have it.
Thank you.
So I'm gonna go here, and I put this slide up here as a trigger to talk a little bit about. This is one of the social workers from Bellevue, and I think this will look familiar to folks here if you had any experience on the COVID units. And I think we're all really well aware of how difficult providing care is without the support system of a patient's family readily available. I mean, the amount of care and support and importance of the patient's family to the patient's recovery, I think cannot be overstated. And COVID disrupted that profoundly. And I think that was probably one of the hardest parts. It's certainly parts from one of the most challenging things I think that I've heard folks here talk about. And that was no different in New York. It was obviously on a bigger scale. And end-of-life care in New York differs, I think, in a lot of ways from end-of-life care in Washington State under normal circumstances. But I think it's worth noting that the proportion of patients who were DNR in New York City was minimal. And there are differences at baseline from that. But I think this pandemic really unmasked so many underlying issues. Bellevue, this is a public hospital system. Bellevue serves an overwhelmingly underserved medical population. And now there's this, large scale event. And then I think it really unmasked a lot of the underlying issues of, mistrust of the medical system. And then we're taking families away from their loved ones who are critically ill. So we're sort of doing things behind the curtain and they can't be there and they can't see that. And then there's a lot of stories in the lay press and the media about shortages and resource constraints. And that was really palpable in my conversations with patients' families, is that they were well aware of that. And what typically had sort of was a little bit deeper below the surface was now sort of right up front with that. So I wanted to just give you the opportunity to read you two quotes from a friend and colleague of mine, Susan Cohen from Bellevue. And this was from an interview that she did. And this really, I think, resonates with the experience there, is to say, I've heard them, meaning families, worry, saying things like, I promise we'll pay you later, worrying about their loved ones not getting care because they couldn't pay. Or patients and families worry about what they read in the paper. Will my loved one get a ventilator if there's not enough? And these were very consistent themes in talking to patients' family members throughout. There was a lot of death. There was a lot of sort of deaths from same family members. So sometimes we had multiple family members from the same apartment in the ICU at the same time. There were staff who had multiple family members die of COVID, and there were multiple staff members who died of COVID or had prolonged hospitalizations. And whether that was, an occupational exposure to COVID or community-based, there's a lot of COVID in the community. I think it's reassuring in some ways to know that many of my colleagues there, we can have a different conversation about antibody testing, but the vast majority of my colleagues there who have worked for weeks in a COVID ICU remain antibody negative and have not had clinical illness consistent with COVID. The patients who survive have a really long road ahead of it. I think we're seeing some good stories come out now about what that looks like. We've never had a population of survivors of ARDS this big at this same time, and I think they have a really long road ahead of them. And there's no question to me that the healthcare workers in this situation will bear long-lasting scars from this event, and I worry a lot about them. I worry about what that's going to mean for their ability to continue in the profession, what that means for them. There was, though, a lot of camaraderie, and there were moments of joy in this, for sure. And I think taking the time, even in the moment, to celebrate the successes in what felt like at times an overwhelming event was really important. So this photo on the bottom here is a staff member from Bellevue who had been sick in the ICU and had recovered. And so this was the group of caregivers seeing him off when he was being discharged from the hospital. The hospital took up a practice that I think many of you have probably heard about, with every time somebody was either discharged or successfully transferred from the ICU to the acute care floor, they alternated between playing a clip of Journey's Don't Stop Believin', if that's your vintage of music, or the Alicia Keys chorus from Empire State of Mind, if that's your vintage of music. But every time that came on, it really sent sort of a palpable lift through the building, because people said there are success stories within this, even though there's more than enough heartache. So what can we learn from these? I think we have two different experiences in two different institutions. What does this mean for us? Will there be a second wave? If you listen to Dr. Fauci right now, he's saying, don't even worry about the second wave. We're still in the middle of the first. And I think, you know, as we look around at these epi curves around the US, it's very clear that not everybody is on the same phase of the curve as New York or as Seattle is. From that, does what we do make a difference? I think we certainly hope it does. And this, I think, is a super cool study. It's, you know, it's an old study from JAMA looking at a much older event. This is looking at the 1918-1919 flu pandemic, and looking at the epi curves in 4 US cities and trying to correlating that with the timing of non-pharmaceutical interventions. And so you can see, I'm not going to go over each and every intervention in this, but you can see that these bars at the bottom of each curve correlate to the timing of that. And you can, again, doesn't prove causality, but you can imagine that there may be a relationship between what happens in the curve and the impact of non-pharmaceutical interventions within that. I personally think early warning systems are going to be incredibly important to try and tell, so that we don't get kind of caught by surprise with lots of community transmission before we know. So that's probably testing. It's doing the equivalent of, you know, influenza-like illness surveillance in the emergency department. Now, COVID-like illness in the emergency department. There's some really interesting work being done about, you know, surveillance of sewage and wastewater to look for signs of COVID and sort of higher levels in the community than may be clinically apparent within the healthcare system. I think there's a really important conversation that needs to be ongoing about non-pharmaceutical interventions and what is the least harm approach. There's undoubtedly, you know, measurable human cost to shutting down the economy. The economy is bad for health, but clearly opening things up has risk as well. And I think we need to have a really cogent, thoughtful discussion about what is the least harm approach there. On a healthcare system, clearly we need to be well prepared to surge bed, to think about what surge staffing looks like, to figure out supply chain and surge supplies. I think we need to model some of the things that we saw in New York about how to manage resources and how to think really creatively about how to constitute, sort of maximize our potential and maximize our resources around how we deliver care. And I think there's a lot of work that we can do around, you know, load leveling and making sure that we're sharing the load across the region to the best extent that we can. I want to stop and just acknowledge everybody at UW, the Department of Medicine, the Pulmonary Critical Care and Sleep Medicine Division, UWMC hospital leadership and UW Medicine leadership. Everybody was incredibly supportive of me going back to New York, and so I was deeply, deeply appreciative and very grateful for that. I do want to recognize my colleagues and friends from Bellevue. They experienced this on a level that I can't begin to imagine. And Neha and Vic and Vish and Sarah Sangavi, who I've not had the opportunity to meet, and those are the folks from the Department of Medicine that I'm aware of who went to New York. There probably are more, and I apologize for leaving them off if I didn't know that. And so I just want to say thanks again for the opportunity to be here. The QR code, I have to put a plug in here. If you can scan the QR code and do a teaching evaluation, I would be very appreciative for my teaching portfolio there. And this is just some street art from these New York City sort of charging stations here. And so it made me think of the people putting teddy bears in the windows for kids walking around as part of their quarantine, searching for teddy bears in the window. And so I liked the sort of bear in the window with a heart. And so thank you again for the opportunity.
Thank you, Dr. Evans. That was fantastic. A couple of questions from the audience. One from Dr. John Cho. He states, given the curves you showed previously and given the profound economic hole that UW Medicine is in because of the cancellations of elective surgeries, do you think that if we have a second COVID wave locally that we should be managing elective surgeries differently than we did this last time?
Yeah, that's a great question. I think there's a lot of people thinking about that question. To me, one of the keys is going to be this early warning system or some sort of, and I know that we've done a lot of work across UW Medicine looking at kind of warning signs for resurgence, and they're monitoring several different metrics to try to get some sort of signal or clue, because I think there is real economic harm. So we don't want to stop doing elective or necessary medical care. There's also obviously non-COVID related deaths that happen during a pandemic. So I think using all the information sources to try and figure out what is going on in our community, to try and to model as best we can what we think a surge may look like or when it's going to start, and using that, as nimbly as we can to make decisions about, do things need to be curtailed at all? Obviously we don't want to if we don't have to from that. So I think using any information at our fingertips and trying to monitor as closely as we can for signs of resurgence before making any decisions about stopping things.
I think we have time for one last question. Dr. Young, did you have a question that you wanted to ask, or we can take?
Yes, yes, Laura. This is a time for various reasons that we all think about even more about stress for care teams and what stress means. And I think also we've all been thinking about that stress is a very good thing because it keeps us alert. We protect ourselves. But you also, of course, mentioned trauma. And were there or are there going to come any good ways of addressing team trauma and people getting over that? Are you hearing anything there? I know we had a different level of trauma, but I think that would be a great lesson to learn.
Yeah, I think that's a really good question. And I think folks, colleagues in New York are doing various different things with different types of groups, right? Whether it be group-based or whether it be individual-based. There, certainly I think psychological support is incredibly important. There have been, after Sandy in New York, we did sort of a similar thing. Was we worked as a group with actually traumatologists, so a psychologist with specific expertise and training in post-trauma, which I found extremely useful in terms of just sort of normalizing experiences, and what we've all experienced is, most of it is within the well-expected kind of coping curve. And so I think even just somebody who can help normalize that is very useful, and that it's not a sign of anything from that. And obviously it has helped to recognize coping that is maybe more harmful, or signs that are more worrisome from that. So we did that. I think everybody does a lot of things informally as well, and so trying to stay in contact with their social network who can help, trying to enjoy things outside of medicine to the best that you can, makes a big difference for that. I think in terms of the health system organizing things, it's mostly been kind of peer counseling, and sort of group discussions with potentially people who have some sort of traumatology background.
Thank you.
Great, thanks, Dr. Evan. I think we're out of time. And thank you for sharing with us today, Dr. Evans. That was fantastic. I just want to make note, this is the last academic grand rounds for the year, and we'll be back on in September. So thank you for joining on the new Zoom format, and we look forward to having you in September. Thank you all.
Thank you.
Thank you.